Thanks for joining us for today's webinar on type 2 diabetes and chronic kidney disease, a discussion on patient engagement and how to manage chronic conditions. This webinar is presented by ADCES in association with AstraZeneca, U.S. Medical Affairs, Cardiovascular and Metabolic Diseases Division. This webinar is educational in nature and contains no promotional or product information. There is no continuing education credit for this webinar, and handouts will not be distributed. If you would like to ask a question during the presentation, you can type that into the Q&A box on your screen at any time, and we'll answer as many questions as we can during the Q&A session at the end. All material is intended for your medical education purposes only. So I'd like to first introduce our moderator today, Dr. Ted Okerson. Dr. Okerson currently serves as a senior field physician within the biopharmaceuticals U.S. medical team for AstraZeneca's Division of Cardiovascular and Metabolic Diseases. Dr. Okerson has a diverse medical and scientific background with over 15 years of full-time clinical practice and leadership experience. For the past 20 years, he's exemplified a successful transition to industry, working as a medical director in various aspects of the pharmaceutical industry, from clinical trial design to late-phase clinical development and medical affairs for various well-known companies. We're excited to have Dr. Okerson and the panel here today, and so I will now turn it over to Dr. Okerson to introduce the rest of the panel.
Thank you, Megan, and welcome everybody. I do want to thank the ADCES for requesting this important discussion. It's great to be able to speak with you all about this topic, which is very important, and again, I just want to welcome you all. We do have a very good panel of experts today who help us to discuss some patient engagement and how we manage these chronic conditions. So I'd first like to start off our presentation with introducing you to each of our panelists. So first, I'd like to introduce you to Donna Stevens. She's a nurse practitioner and certified diabetes care and education specialist in the Department of Endocrinology at the University of Alabama at Birmingham. She's worked in nephrology for 16 years before joining her current team. She served as an author and reviewer on several articles and papers related to diabetes, including the co-author of the ADCES practice paper on diabetes and kidney disease, and a reviewer on the updated competencies for diabetes care and education specialists. And next, what I'd like to do is introduce you to Dr. Susan Guzman, who is a director of clinical education. She's the co-founder of Behavioral Diabetes Institute. And as a licensed clinical psychologist who specializes in diabetes, her clinical and research interests include overcoming barriers to management, family issues with diabetes, and promoting attitudes of living well with chronic illnesses. She co-developed and co-facilitates BDI's continuing medical education programs. She integrates a viewpoint of acceptance and wellness to help people better utilize their strengths in living life with diabetes. And then finally, I'd like to introduce you to my colleague, Dr. Carrie Cooper. Dr. Cooper is currently the Vice President of Medical Affairs of the U.S. Renal Division at AstraZeneca. Dr. Cooper most recently led medical affairs in nephrology at Amgen for nearly a decade before joining AstraZeneca in 2018. Prior to that, Dr. Cooper led direct patient care as a practicing nephrologist for over 35 years. He served patients in many capacities with a focus on chronic kidney disease, including his time as a medical director for their dialysis unit. He was trained at Yale University, where he also advanced to the position of the Associate Professor of Medicine. So welcome, panelists, and we look forward to discussion later on through this presentation. So as we get started, I think it's important to understand what are our objectives in this presentation. What do we hope for you to take back with you when you see your patients? And the first of that is to understand the burden of chronic kidney disease. How common is it? What is the prevalence of chronic kidney disease, and what does it mean to our patients? We also need to understand the risk factors for chronic kidney disease, but also the fact that this is a progressive disease. And so we need to really appreciate that as we think of screening and treatment going forward. We need to identify then the risks of chronic kidney disease, particularly in patients with type 2 diabetes, since that's the focus of what we typically do in clinical practice. And then we want to review the screening, but also the treatment strategies for chronic kidney disease so that you can not only help to educate your patients, but educate other providers so that we can continue to battle this chronic condition. So before I get started with a little more didactic discussion, I do want to present a couple of cases that you will see as we move forward during this presentation. So let me just talk about this one. This is the first case, a 52-year-old woman. She has type 2 diabetes that was diagnosed about a year ago, and she's referred to you for evaluation of proteinuria that was just diagnosed or just discovered 3 months ago. Importantly, her family history is positive for diabetic nephropathy. When we do a physical exam, her blood pressure is 140/95. Her fundoscopic exam is normal, and otherwise her physical exam is unremarkable, and I'm going to assume they looked at her feet. Laboratory studies showed that she had a serum creatinine of a 0.9. When you do a urinalysis, there's 3+ protein. Sediment is unremarkable. The second case that we'll touch on later on today is a 45-year-old African-American man. He presents for initial evaluation in your nephrology clinic. He's had type 2 diabetes for 7 years, and it's been well controlled. He also reports that he has high blood pressure for the past 5 years, and that he has been consistently at his treatment targets with a blood pressure currently of 135/75. When we do his physical exam, it's notable that he has about 1+ lower extremity edema to about the mid-shin, and otherwise his physical findings are unremarkable. His blood pressure is currently managed with chlorothalidone, 25 milligrams a day. And when you look at his laboratory, there's some key findings. Are serum potassium of 4.1, his creatinine is 1.3, and his albumin to creatinine ratio is 1,257 milligrams per gram, and his hemoglobin A1C is 6.9. So those are the two cases. We'll talk about them later, and I'll give you some questions that you can think about as we approach these patients later on. So in keeping with our objectives, let's move into the burden and the prevalence of chronic kidney disease. And this is somewhat interesting in that when you look at the entire adult population, it's estimated that about 1 in 7 people, so 14–15% of people in the United States adults have some form of chronic kidney disease. And looking at the latest data available in 2016, the all-cause mortality rate for chronic kidney disease in patients who are Medicare age is 10%. So it's a fairly significant mortality rate for people who have chronic kidney disease. But moreover, when you look at the expenditures for chronic kidney disease in this same population, it represents about 25% of Medicare spending. And I think that really highlights the significant burden of chronic kidney disease in our Medicare population, but it doesn't even touch upon those who are below that age who also may suffer with this condition. Now, there are a number of risk factors that we need to remember and pay attention to as far as what can increase the risk of chronic kidney disease. And so on the left of this slide is a listing, if you will, of some of these conditions. And I'm going to start at around the 10 o'clock position. And that's a condition of hypertension. And this is something that as adults, we know a lot of adults come down with hypertension, and certainly the older we get, the more likely it is that people develop hypertension. But we also know that clinicians, on the whole, don't really do a very good job of getting people down to reasonable blood pressure goals. But certainly controlling blood pressure is a key factor in helping to reduce the prevalence and the incidence of chronic kidney disease. And then, of course, there's diabetes, and we're going to dive into this a little bit more. So I'm going to skip past this one and on to the 1 o'clock position there, and that is family history. And I would argue that a lot of us as clinicians, we forget to ask about family history of kidney disease. We talk about heart disease and stroke and cancer, But it's important to also take that family history of chronic kidney disease because that can also portray an increased risk in these individuals. And then, of course, as we get older, we lose nephrons, creatinine clearance starts to gradually decline. So age is certainly a factor. It's not one of those things that we have established a particular cure for at present. And then race and ethnicity. Certain races and ethnic groups have a much higher prevalence of chronic kidney disease. And then down at the 6 o'clock position there is obesity. And we know that that is certainly rampant. I know during this COVID time, some people have lost weight, but I think we now talk about the COVID-16 or the COVID-19 or whatever it is, that even obesity is potentially getting worse as we have become potentially less active. And then finally is atherosclerotic cardiovascular disease. And why I left this for last is we need to remember that when people have atherosclerotic cardiovascular disease, it is a systemic disease. It's not just present in the heart or in the cerebral vasculature. When you have atherosclerosis one place, you likely have it others. So the presence of atherosclerotic cardiovascular disease, whether it's an event or not, we need to remember that these people likely have some form of chronic kidney disease, but they're certainly at risk. And the graph on the right looks over time both the simulated incidence and the prevalence of chronic kidney disease. And I put the definitions down at the bottom of this slide so we remember, but incidence is newly diagnosed patients. It's either the number or proportion. Prevalence is actually all those who have the condition. So that includes incidence plus those who we already knew. And as you can see from 2020 to 2030, that both the incidence and the prevalence of this disease is supposed to go up by roughly 1,000 cases per million, so a significant increase over time. Now, it's important to remember, and we've kind of touched on this, that there is a progressive decline in renal function with age, but also in chronic kidney disease. And this slide lists the stages for us, but we're going to go into a little more detail in a subsequent slide, so I'm going to skip through that part, other than to show that there's both an early stage and a late stage, but throughout this, there's a decline. And initially, there's not a lot of symptoms for chronic kidney disease, which is why it's important for us to remember to screen our patients and to help remind our colleagues that screening is important. And then as this disease progresses to more later stages, then there's a lot of symptoms that can occur. Fatigue, poor appetite, nausea, vomiting, metallic taste. They can have pruritus, itching, of course, edema, and pallor and altered mental status. So people, as this disease progresses, don't feel well at all. So it's important to prevent them from getting to this stage if at all possible. Why is it important in this progression, why we want to forestall this? It's not just that they feel badly, but as these three graphs represent, there's a health consequence as well. So the graph on the left shows different, well, actually in common, all three of these graphs look at different levels of chronic kidney disease. So on the left of each of the graphs, on the x-axis, is people who have a GFR over 60, and as you progress across to the right, it's those who have a GFR under 15 or stage 5 chronic kidney disease. And as you'll note, people, as they progress from more normal renal function to decreased or worse renal function, have an increased rate of hospitalization. And it's nearly tenfold increased. Now, if you look at the center graph, when we're looking at cardiovascular disease, which is a key reason why these people die, and actually a lot of them never even reach dialysis stages because they die of cardiovascular disease or other conditions. But you'll note here that it's almost a 20-fold increase incidence or risk of dying of cardiovascular disease. And then finally on the right, if you look at just mortality overall, again, you'll see a 10-15% fold increase risk of dying of any cause as people develop worsening stages of chronic kidney disease. So clearly, we need to identify it early and do what we can to forestall and prevent progression to some of these later stages because of not only the symptoms, but also the health consequences. Now, one of the key drivers of chronic kidney disease is diabetes. And This is a graph that kind of gives us an idea of how significant this is in diabetes. I do want you to note that 1 in 5 patients have what we call chronic kidney disease, which is generally understood to be an estimated GFR of under 60. Okay, and so that's the right portion of this slide. Now, if you were to add up these numbers, including the 2 bars on the left, it doesn't hit 100% because this represents the roughly 38, 39% of patients who have diabetes but who also have chronic kidney disease, either manifested by a low GFR of under 60 or some degree of albuminuria. And as that disease progresses, as that GFR goes down, the severity of that disease increases. So clearly, we need to remember that roughly 1 in 5 of our patients that we see in our clinic, and it'll vary from depending on your population, but 1 out of 5 people who walk in your door have some degree of chronic kidney disease with a GFR under 60. So let's look at how this actually progresses and the long-term progression of this disease. So on your slide is an example from the UK-PDS, which is a study that was done in the United Kingdom in patients who were newly diagnosed with diabetes. And we've gleaned a ton of data from this study. So on the left half of this slide, you'll note that there's 3 degrees of protein loss: normal, microalbuminuria, which is anywhere from 30 to 300 milligrams per liter, all the way up to macroalbuminuria. And how does it progress? So those people who have normal albuminuria, they don't spill protein, they actually progress at a rate of about 2% per year from being normal to microalbuminuria. Again, anywhere from 30 to 300 milligrams per liter. But if those people have microalbuminuria, once you start to spill protein, you'll note that the rate is roughly 50% greater to progress from micro to macroalbuminuria. And then if we follow these patients long-term, no matter how they were treated, and as I mentioned in the last slide, about 38, 39% of people develop albuminuria, and in this particular study, it was more than 1 in 5, it was nearly 1 in 3 who developed a GFR of under 60, which we call chronic kidney disease stage 3 through 5. And as I mentioned, diabetes is the leading cause of chronic kidney disease, with roughly half the patients who develop CKD having diabetes. But we also need to remember those risk factors that I talked about, one of those being hypertension. So hypertension is a large part as well, whether they have diabetes or not, of promoting, if you will, the development of chronic kidney disease. And then there's a host of other conditions such as polycystic kidney disease, glomerulonephritis, and other unknown unknown etiologies. And then on the right half of this slide, it's important that we remember that no matter what study or what population you look at, having chronic kidney disease affects their quality of life, not only how they feel physically, so their physical components scale, but mentally as well. So it takes a toll both on the physical and the mental well-being of our patients. And we're going to hear a little bit more about that when we get to our panel discussion. So what do we do? How do we screen? Well, this is a slide that helps us to classify chronic kidney disease, and we look at 2 basic components. We look at function, and we look at protein loss. So the cartoons, if you will, and the 2 kidneys, we're going to review those for you, and I'm going to start with the one on the right. So looking at the glomerular filtration rate of 90 or more is what we call a grade 1 or G1, and as we progress, you get G2, G3, or stage 3, down to 4 and 5. So again, right there in the middle of that kidney, anywhere with a GFR from 30 to 59 is chronic kidney disease stage 3. When you get from 15 to 29, that's stage 4, and below 15, you have a stage 5 chronic kidney disease. The kidney on the left looks at the categories of albuminuria. And so again, we mentioned this on an earlier slide that if it's under 30, that it is considered normal or minimally increased. If you have anywhere from 30 milligrams per liter to 300, it's considered moderately increased, and that's an A2 classification. And then the A3 classification is those who have macroalbuminuria, and that is more than 300 milligrams per liter. What we also can see then is with albuminuria is you also can have some electrolyte abnormalities. You have if we were to biopsy the kidneys, histologic abnormalities, and structural abnormalities. So it's important for us to screen for chronic kidney disease in two fashions. One is glomerular filtration rate. Where do they fit along that right kidney there as far as GFR? But also the presence of albuminuria and how much albuminuria may be being spilled. So when we look then, that's a screening target. When we look at what do we do for therapeutic intervention, we have to remember a couple of things. Firstly, we go back to our risk factors, and that's the couple rows on the very top. Some of those things that we mentioned before, hypertension, age, diabetes, etc., hypovolemia. Again, reminding you, take a family history. And then our objectives in our treatment for this disease is to reduce the damage to the kidney, reducing the amount of proteinuria, taking care of volume excess, being aware of the hypoxia and the tissue hypoxia that occurs, the tubulointerstitial injury that also occurs. But something that we're going to touch on in a little more detail is also that increased intraglomerular blood pressure, what we would call intraglomerular hypertension. And this is really something that clinicians sometimes forget about, and I think it bears reminding them, because just like in hypertension, when you have high blood pressure, you can damage the end organs, the brain, the heart, the kidney. With it having high blood pressure, if you will, within each glomerular unit causes damage to that glomerulus. So we need to also keep in mind that we need to treat the blood pressure, if you will, within that each glomerulus. And then we need to address complications of chronic kidney disease as they occur. Things like anemia, electrolyte imbalances. But we also need to remember that the kidney is just not a filtering organ. So blood and bone disorders, bone disorders can also occur, metabolic disease, metabolic acidosis in particular, and then we also have to address the volume status of our patients. So when you look at the various organizations, from the kidney organizations, KDIGO, to the European organizations and all the way over to the ADA, they all have screening recommendations for these patients. And if you look in the upper left box, that's our kidney organization, KDIGO. And so this is more than just people with diabetes, but it includes those who have hypertension, who have chronic kidney disease, cardiovascular disease. That's, as I mentioned early on with the risk factors, when people have these items, we should be screening these people for the development of chronic kidney disease and intervening early to prevent progression. And then on the upper right is the American Diabetes Association. So if we were to diagnose somebody with type 1, certainly within 5 years or more, we need to start screening them for CKD. And in patients with type 2, we should do this on an annual basis. Now, what happens if we find chronic kidney disease? And that's the bottom row. So in this case, and I think this is really important, it's relatively new, but if whether you're talking to a cardiologist, a nephrologist, a diabetologist, the recommendations are all very, very similar. That is, if you have a patient who has chronic kidney disease, particularly if they have a GFR of 30 or more, or if they have any amount of proteinuria, whether it's micro or macro, we should be treating these individuals with an SGLT2 inhibitor. So that's a key component, and it comes from cardiologists, nephrologists, and diabetologists. So something that we need to make sure and educate our patients, but educate our colleagues as well. And we're going to talk a little bit more about SGLT2 inhibition, show you those data. So at this point in time, I would like to stop and engage our panelists. And I think what I'm going to do is start with, and I'll do this each time just to kind of keep it orderly, but I'm going to start with Dr. Susan Guzman. And for all three of you, based on the recommendations that we've just heard about screening patients, about assessment, could you give us some thoughts about how and when you would recommend that we begin screening patients? So, Susan, can I ask you to go first?
Yes, I really appreciate this conversation. My dad was on dialysis the last year of his life, and he passed away 2 years ago, and I also live with chronic kidney disease. So just to add to this conversation from the patient perspective a little bit, and the emotional burden of life with chronic kidney disease, I think it's really important to remember that when we add a complication to somebody who's already living with diabetes, we're adding not just another medication or perhaps additional restrictions in a diet, but there's another emotional burden that goes with that. I think that how we talk about when we're screening people for complications, and if they do screen positive for proteinuria, and how we have that conversation with people, I think is really important. I think a family history, when you have a family history, one of the things to really remember is that there might be a scary story associated with that information that you're about to share with them. So to remember that there's a lot of tough feelings that might be going with the fact that somebody is screening positive now for having chronic kidney disease, and to be sensitive to the fact that there's a whole lot more that you probably can't see or know unless you ask, like, what does this information mean to you? So just when you're thinking about your question about screening, just to remember these aren't just lab values that you're sharing with these people, but this can be a really scary transition for a lot of people.
Thanks, Susan. Donna, what are your thoughts?
One of the things that we see in clinical practice all the time is that patients who present who already have proteinuria are unaware that they have chronic kidney disease. And so I think it's important, a lot of times they may know that they are on a medication for protein that's spilling into the urine, or that they just started on a new blood pressure medication to help with proteinuria, but they may not realize that they actually have chronic kidney disease. And so I think it's important for us to educate patients about what's going on with them, so that they can be proactive in their care and be a part of helping to prevent the progression of the disease. So if you're not aware of what's going on with you, you certainly can't be active participant in moving forward with your care. So I'm not sure about the audience. I know that people are here at different stages of their career, and so maybe some of the people that are joining us today are new to diabetes care, and some of you may have had years and years of experience. So for those of you who are new here, let me just say that every single year the ADA puts out new clinical practice guidelines, and they come out in January. And so that's sort of a Bible, if you will, for care for patients with diabetes. And so every single year in January, I go and look at the guidelines to see what's changed and what's happening. And so I just wanted to mention that as well. We screen patients with type 1 diabetes after 5 years, and patients with type 2 at the time of diagnosis, and then everybody annually thereafter, just according to the ADA guidelines.
Excellent. Thanks, Donna. And Dr. Cooper, what do you think? What are your thoughts?
Well, first, Ted, I wanted to say, listening to your excellent talk, I think you're actually a closet nephrologist, so I don't know why you have a cardiology degree. You gave a wonderful talk. So just to expand on what we've already heard, a couple of points really resonate to me. One is, again, the very accurate diagnosis of the presence of proteinuria. And just a reminder that the standard urine dipstick that might be used in the office is not adequate or sensitive enough to detect, microalbuminuria, which is really important to know as the earliest manifestation of clinically significant renal disease. And that does require a direct action to order that. And it's a very simple test. It's not a 24-hour urine. It's a spot urine and a simultaneous blood. So simple test to do. The second thing is I very much like the comment that was just made about getting the patient involved. Every time a patient gets blood drawn, they always want to know their cholesterol. And maybe it took decades to get patients to realize, well, I want to know not only my cholesterol, I want to know my LDL cholesterol, I want to know what medications I'm on for it. Yet I think patient awareness of the significance of their labs, as well as the significance of the medications they take, is really deficient. So EGFR is almost unavoidable. If somebody orders a serum creatinine, it almost gets spit out on the laboratory report automatically. But I agree with the point that very few patients are told, because clinicians don't want to tell them things patients don't want to hear. But to tell a patient, you do have a slight decrease in EGFR and you have microalbuminuria is very important for the patient to know. Similarly, I think it's important for patients to know that the medications they're on, whether it be ACE inhibitors, angiotensin receptor blockers, and hopefully SGLT2 inhibitors, are not just there as blood pressure or diabetic medications. They're there as medicines to protect their kidney function. And I think the more patients are educated and understand that, the better we will be able to be to ensure, that these patients are started on these medicines and importantly remain on those medications, which have, proven efficacy and guideline recommendations regarding their use.
Excellent. Well, thank you. That's some very helpful information and really helps to emphasize why it's important that we screen these individuals and what patients face. So having talked a little bit about screening now, let's move into some therapeutic options on how we treat these patients. And I talked about earlier, and I really hit on this, was the fact that these patients often have glomerular hypertension. And it's very, very similar to what we see in systemic hypertension. And I talk to my patients and I give them kind of an analogy. If I have a garden hose and I have it on full blast and pointed at the dirt, what is it going to do to that dirt? It's going to dig a hole. That's what high blood pressure is doing to your brain and to your heart and things like that. And then if you kink that hose and make that drip a lot less forceful, you're going to, that's essentially lower the blood pressure. You're not going to dig a hole in that dirt like you would if the pressure is high. So I tend to give examples with my patients to help them understand, how is that high blood pressure causing the issue? And so when you're looking at the glomerulus, we actually see a similar thing that we can do. One of the approaches then is putting a kink in that hose, if you will, and that is to constrict the arteriole carrying blood to the glomerulus, and that's represented on the left half of this slide. So that's one approach. And then if we dilate the arteriole leaving the glomerulus, both of those things lower blood pressure. So by decreasing that glomerular pressure by constriction of the afferent, dilation of the efferent, you're lowering the pressure within the glomerulus, you're reducing that albuminuria, and by doing so then, although that initially results in a GFR decline because you're reducing the amount of blood getting to the glomerulus, you actually slow that decline of GFR over time. And that's one of our therapeutic goals. So clearly, what we can do within each filtering unit of the kidney is important at reducing progression. Now, we talked about SGLT2 inhibitors, that these are kind of the new kids on the block to help to prevent and treat chronic kidney disease. But wait a minute, I thought these were drugs for diabetes, yet they help the kidney. So how do they work? So on the left half of this slide, the left column in green is some of the various mechanisms by which SGLT2 inhibitors can help facilitate protecting and preventing further damage to the kidney. And at the top there is what we've just talked about. By constricting the afferent arteriole, we reduce that glomerular hyperfiltration that people, particularly with diabetes, early in the disease get. And so we're reducing the pressure within that glomerulus, within each glomerulus. We also know that there's an improvement in neurohormonal activity. So by giving an SGLT2 inhibitor, you reduce the intrarenal renin-angiotensin aldosterone system activity, and you decrease the nervous system activity as well, the sympathetic nervous system. How that happens mechanistically, still to be determined, but we know that it happens. And I just want to give you a quickie as to why we know that. Because if you lower someone's blood pressure, what do you expect to see? You expect to see a compensatory increase in pulse rate. Well, we know when you give an SGLT2 inhibitor, there's anywhere from 2 to 5 millimeters of reduction in blood pressure. we don't see that increase in pulse rate. So something, not an ACE, not from ACEs, not from beta blockers, but something in addition to how those agents work, we are reducing that sympathetic nervous system activity. Thirdly, there's data that we reduce inflammation and fibrosis in the kidney. How do we know this? Well, we've seen that by giving SGLT2 inhibitors, there's a decrease in inflammatory markers, and there's a decrease in fibrosis. So this is clearly important in helping to reduce that progression of kidney disease, and by also reducing that glomerular filtration rate, that glomerular hypertension, we're reducing the renal workload. We're reducing the effect or the development of that local tissue hypoxia. And so that occurs with decreased solute transport. We're decreasing oxygen demand on the kidney. And so overall, when you put these mechanisms together, we see that middle column. We're able to stabilize the decline in the GFR. We lower the blood pressure, not only systemically, but also within the glomerulus. But we're also helping to reduce the tubuloglomerular injury. We reduce the amount of protein loss in the kidney. We're reducing the ischemic injury, which occurs from all these factors. And importantly and interestingly, we increase the hemoglobin hematocrit. And when you think about it, if you have more oxygen carrying capacity, more red cells, you're able to even further address that hypoxia in the local tissue environment. I do want to point out that when you look at the initial labels for SGLT2 inhibitors, we thought that that increase in hemoglobin hematocrit that we saw was mostly due to hemoconcentration. We now know that that's not really the case, that there's actually, and I won't go into the physiology behind it, but there's actually an increase in erythropoiesis. So you actually do develop more red cells. You produce more red cells. And so again, that has a positive effect as well. And so on the right then, not only do we help to prevent the development of chronic kidney disease when we use SGLT2 inhibitors early in the disease process, but we also help to prevent against the progression of this disease. And then overall, we're helping to preserve renal function over the long term. Now, let me go into some specific data on SGLT2s regarding renal function. So this looks at data from the cardiovascular outcome trials that are required of all diabetes agents, in this case the SGLT2s, and plus the Credence trial with Invokana, a renal study. And on the top half of this slide, it's broken down into patients who we know have atherosclerotic cardiovascular disease. And if you'll note in the blue error bars on about the right third of the slide, they all are to the left of that dotted vertical line of unity. So no matter which study you want to look at, in people who have known atherosclerotic disease, there's a benefit at preserving kidney function, kidney outcomes. The bottom half of this slide looks at patients who have just risk factors. We don't know that they have cardiovascular disease, atherosclerosis of any note yet, but when you look at the data from these outcome trials on the left again, in patients who just have risk factors, quote, just, we can again see consistent benefit by adding an SGLT2 inhibitor to these patients as well. Now remember, these studies were done in patients with diabetes. Here's an example from a cardiovascular outcome trial known as DECLARE, in which most patients, 93% of them, had a GFR over 60. And 60% or so did not even have cardiovascular disease that we were aware of. They just had risk factors. And so you'll see, again, with an SGLT2 inhibitor, there's that initial constriction. There is a constriction of the blood coming to the glomerulus, and so that GFR in the blue drops a little bit, but then it stabilizes. And compared to placebo, you can see that as you continue on the SGLT2 inhibitor, the GFR slope is less than those on placebo, which can include an ACE/ARB treatment as well. We're going to go into this in a little more detail. Let's talk about protein, because remember the components of chronic kidney disease is not just GFR, it's protein loss as well. This looks at microalbuminuria in that same study. And so on the top half of this, it's looking at improvement from baseline, whether they went from macro to micro, micro to normal, or whatever you want to look at, you'll see that there was a benefit. And in kind of the middle of this table, the middle column, the Kaplan-Meier rates for DAPA and from placebo, and you'll note that you're actually able to get a significant reduction, a significant improvement in lessening that amount of proteinuria loss that we see in patients. The bottom half of this slide shows the progression. And so I want to call it to your attention the numbers, the KM rate under dapagliflozin. So on the top half of this, improving albuminuria, large numbers. Below that, actual worsening of albuminuria, small numbers. So yes, some people, despite adding SGLT2, may continue to spill more protein, but the vast majority of them will go the right direction and reducing the amount of protein loss. So stabilizing GFR, reducing proteinuria. Two of the things we want to look at. Now, there are a number of studies looking specifically at chronic kidney disease with SGLT2s, 3 of which are completed. The 3 on the left, Credence with Invokana, canagliflozin, DAPA-CKD with dapagliflozin, and empakidney with Jardiance or empagliflozin. Those are still underway. The empagliflozin is underway. The 2 in the green are completed. And on the far right is a novel mineralocorticoid receptor antagonist. That study is also completed as well, but that compound is not yet on the market. These studies look at different populations. So whenever you're reviewing a study, make sure and look at the populations, and that's the 3rd row in this particular table. And so you'll note the Credence trial with canagliflozin looked at patients only with type 2 diabetes and only with macroalbuminuria. So this was true diabetic nephropathy patients, about 4 to 5% of our diabetes population. DAPA-CKD, the next column over, looked not just at patients with type 2 diabetes, but actually based on our physiology, what we know these compounds can do, looked at patients who didn't have diabetes, anywhere from GFR of 25 all the way up to fairly decent kidney function of 75. And these patients had not just macroalbuminuria, they could have microalbuminuria as well. The study that is still underway with empagliflozin in the gray column looks at a little bit broader population. Some people may not have any albuminuria whatsoever, but they would need to have a CKD based on the GFR. Now the next row across, the primary endpoint, similar between Credence and DAPA-CKD, and we're looking basically at the chronic doubling of serum creatinine, if you will, end-stage kidney disease, renal or cardiovascular death. EMPA-KIDNEY, that study is looking at a 40% reduction in GFR. We still have to wait what those results look like. But let's look at the ones we do have information for. So when you look at canagliflozin and renal outcomes in patients who have diabetic nephropathy, when you look at that composite outcome of end-stage kidney disease, doubling of serum creatinine, renal or cardiovascular death, that primary outcome you see is reduced by 30%, and that's represented by the blue line in the Kaplan-Meier curve in the upper left. But when you take out the cardiovascular death and just look at those kidney-specific outcomes, you see a 34% relative risk reduction. That's in GFR, that's in the composite outcome. Now when we look at the components of what we've talked about as far as protecting the kidney, the effect on albumin, the effect on GFR, the upper right is looking at the albumin to creatinine ratio, and you can see we decrease the loss of albumin and hold that stable over the course of the trial. And then just like what we saw with dapagliflozin and the GFR, an initial decline, but then a relative flattening out or certainly a decrease in the rate of decline of that GFR over time. So in patients who have type 2 diabetes and kidney disease, when you look at the risk of kidney outcomes, cardiovascular events, it's lower in that group of patients treated with canagliflozin. What about dapagliflozin? Remembering this trial is different in that it included patients with or without type 2 diabetes. So in this particular study, they took patients who had to be treated with the maximally tolerated dose of an ACE or an ARB, so medications we know are protective. They were just randomized to dapagliflozin 10 milligrams or placebo. And then we followed them over time for a composite of either 50% or more loss of eGFR, end-stage kidney disease, renal or cardiovascular death, and then a whole host of secondary outcomes, which I will review for you in subsequent slides. This study was stopped early because of overwhelming benefit. What did we see? So here on the left looks at that composite outcome, hazard ratio or reduction in risk of 39% over this period of time, with a p-value that's slightly significant with 7 zeros in front of it, and a number needed to treat of just 19. Now, when you look at the different components, you'll see here, this is looking at the very top, that's that primary composite outcome which I just showed you. If you look at the components of that primary composite outcome, you'll see that no matter which component you want to look at, the point estimates, those blue dots, are all the way to the left of that vertical line of unity. So whether you're talking about worsening GFR by 50% or more, end-stage kidney disease, etc., you'll see that those are all to the left. The bottom portion of this table looks at the secondary outcomes. And yes, we're impressed by the overall data, but I think here's some really, really interesting data points. If we just look at the kidney endpoints, can't talk all of a sudden, the GFR decline, the end-stage kidney disease, renal death, you can see that there is a 44% reduction in this outcome. If you look at reduction in cardiovascular death or hospitalizations for heart failure, we see similar to what we saw in the DAPA heart failure study, which was reduced ejection fraction heart failure with or without diabetes. We see here a 29% reduction in this endpoint. And then here's what's truly interesting beyond this data that I've showed you so far. All-cause mortality, not just cardiovascular, not just renal endpoints, not just CV death and hospitalizations, but all-cause mortality was statistically significantly reduced by 31% when we added the SGLT2 inhibitor dapagliflozin to patients with chronic kidney disease, whether they had diabetes or not. So this is truly something remarkable for something that we thought was a diabetes medicine 5 years ago. Now, when you look at kind of the harder renal endpoints, that real severe kidney disease of the risk for dialysis, needing a kidney transplant, or kidney death, this is kind of more of an exploratory sort of look. But we see very, very similar numbers. The curves start to split early at about 8, 9, 10 months, and we result in a 34% reduction by adding dapagliflozin to these patients. On the right half, when we look at the same sort of data, canagliflozin, we see a similar number with this SGLT2 inhibitor as well of about 28% relative risk reduction. So let me summarize then how we would manage chronic kidney disease, and then we'll get to our panel again. So our current management for type 2 diabetes or chronic kidney disease is RAS inhibition, and this can be with an ACE inhibitor, it can be an ARB. What do these medications do? They dilate the efferent arteriole, where the blood leaves the glomerulus. We can use mineralocorticoid receptor antagonists, MRAs, and they decrease the effect of aldosterone. We can use SGLT2 inhibitors, and we kind of reviewed what happens here, and there's a whole lot of mechanisms of action that we went through, not just what's listed on this table. And then we also need to remember that GLP-1 agonists also have some benefit to the kidney. So when you look at pharmacologically, in addition to what we talked about with ACE and ARBs, some of these things that these medications do is to decrease the tubular injury, decrease the fibrosis. We're able to reduce the glomerular pressure by, in the case of an SGLT2 inhibitor, constricting that afferent arteriole, but we also protect against endothelial injury, oxidative stress, and inflammation. And then we need to remember that we treat the conditions or the complications, if you will, of chronic kidney disease. And there's a number of them, and it's kind of beyond the scope of my initial discussion, but things like volume overload, sodium retention, hyperkalemia, and we have a lot of different ways we can treat this, from dietary restriction to a whole host of medications. Sometimes, as we remember, one of the complications is acidosis, so we have sodium bicarb. There's imbalance of calcium and phosphate that's going to occur, so we can treat these with phosphate binders or calcium mimetics. And then remembering that as renal function declines, anemia can occur, so we have the option of using erythropoiesis-stimulating agents. We may need to replenish their iron stores as well. So let's go now back to our cases. They're somewhat unique, and we'll get our panel's perspective on each of these. So this was the 52-year-old woman who just has a history that we know of type 2 diabetes, and just 3 months ago started to spill some protein in her urine. She's got a blood pressure of 140/95. Otherwise, physical exam's unremarkable. Creatinine looks reasonable at 0.9. I don't know what her weight is. So, and she does show 3+ protein in the urine. So as we think about this patient, which of the following statements is correct? The fact that we found proteinuria 6 months after diagnosis, does that argue against diabetic nephropathy? The fact that she has a normal fundoscopic exam, does that argue against diabetic nephropathy and we need to think of some other diagnosis? Or is this diagnosis most likely diabetic nephropathy? And then finally, is the answer that the increase in blood pressure in the majority of patients with diabetic nephropathy are only seen after the kidney starts to falter. So in this case, I'm going to, if you don't mind, I'm going to go to Donna first. What are your thoughts on this case and the answer? And then I'm going to go over to Susan and then to Terry. So Donna, what are your thoughts?
Okay. Well, the thing that jumps out at me is that the fundoscopic exam is normal. I would expect that if she had 3+ proteinuria, if it were related to diabetic nephropathy, she would also have some findings on her fundoscopic exam. So that's kind of what jumps off the page at me when I'm looking at this case. And then also her blood pressure control. Her blood pressure is elevated and in the presence of having 3+ proteinuria.
And Susan, what are your thoughts?
Thinking about what you said about family history there, and the fact that this this woman has currently elevated blood pressure, and just what we now know about the prevalence and incidence rates of chronic kidney disease. I'm a psychologist, so I'm really not supposed to say, but I'm leaning more towards this is not necessarily diabetes specific, but has to do with blood pressure and perhaps a family history of chronic kidney disease.
And Dr. Cooper, what are your thoughts?
Yeah, you shouldn't be giving such hard questions. That's what I think are my thoughts. But so I think there are a couple of points here. First of all, I think when we talk about type 2 diabetes, I mean, just because somebody was diagnosed with type 2 a year ago, I think we know the actual duration of glucose intolerance may be substantially longer than that. So I don't think the short duration of the diagnosis is really that critical. The fundoscopic exam also, yes, it does. It's a little. If this was a type 1 diabetic, I'm a little bit more concerned about the absence of retinopathy. In a type 2 diabetic, you know, even though yes, I think it should point the short duration clinically and the absence of retinopathy certainly should point to another diagnosis. And if I was seeing this patient in the office, I wouldn't immediately jump to the conclusion you obviously have diabetic kidney disease. I would probably do the usual workup I would for other secondary causes of chronic renal dysfunction. All that being said, my guess is the patient probably still has early diabetic kidney disease, even though the serum creatinine is completely normal, but definitely you know, other diagnoses should be considered.
Excellent. Thank you. And in our second case with the African-American gentleman with a longer history of diabetes, blood pressure is a little bit lower, 1+ edema. He has a number of different lab values there with blood pressure being treated by chlorothalidone. And just in the interest of time so we can keep going, I'm going to just address this one to Dr. Cooper. What should be added to his regimen to slow the progression of diabetic nephropathy?
Yeah, so this is a very good question, I think. So first of all, we would probably look at the blood pressure and say within, you know, the current recommendations for diabetic kidney disease, you know, this is probably a pretty good level of blood pressure. You might say you want to see the systolic and diastolic both a little bit lower, and again, there are new diabetes CKD guidelines that have just come out, and I would probably say there is both room, A, for a little better blood pressure control, and B, that the hemoglobin A1C in this quite young patient at 6.9% could stand some improvement as well. So I think the addition of an ACE inhibitor or an angiotensin receptor blocker would be appropriate. And again, it goes back to the studies that you've reviewed, remembering importantly that the benefits of SGLT2 therapy have been seen on top of maximally tolerated ACE or ARB therapy. So I would think a first step in this patient, the potassium is normal, would likely be the addition of either an angiotensin receptor blocker or an ACE inhibitor. The last answer is not correct because it has been, even though you might think that simultaneous attack on the renin-angiotensin system might be helpful, in fact, the risk of adverse events with those regimens have precluded the use of combined therapy in that regard. That would be my first step, but I would still think that likely this patient will be a very strong candidate for an SGLT2 inhibitor at some point. But I think the correct first step would be to add an ARB to the regimen as we've seen.
Excellent. And Donna, what about diet? Would you do anything in this patient from a diet perspective? What are your thoughts?
Yes. We certainly want to make sure he is watching his sodium intake. One of the points that I wanted to make is that for the very first time, the ADA guidelines in 2020 suggested that you could add an SGLT2 in someone who has chronic kidney disease or congestive heart failure, regardless of what the A1C level is. So I agree with what Dr. Cooper said. From my perspective, I would certainly have a strong consideration for the addition of an SGLT2 in this patient. That I got off subject about the diet, but certainly he needs to be watching his sodium intake.
Okay. All right. Well, let me just quickly summarize what we've heard, and then we can take a little more from the panel. So I think what's important to do is need to remember that chronic kidney disease is a significant problem in adults, and so we need to be screening regularly by intervening early if we need to, with a goal of preserving kidney function, reducing albuminuria. So we need to be remembering those risk factors that we talked about, treat those risk factors aggressively, and if CKD develops, treat those conditions with the ultimate goal not just to preserve kidney function, but we want to prevent cardiovascular events. We want to prevent that morbidity that we've discussed can occur with chronic kidney disease, and of course the mortality risk as well. So knowing that this burden is so significant, is there any other advice you'd like to give to healthcare professionals as how we can work together? When do we need to refer? How do we get people to intervene early to get the appropriate treatment? And I know Dr. Cooper has may have to leave us a little bit early, so I'm going to start with you, Carrie.
Yeah, I think this is a critical point. We have amazing data now, and it's interesting that on our panel, and including you, we have representations from cardiology, nephrology, endocrinology, diabetes management. And I think our biggest challenge is how do we figure out a holistic approach to these patients, that it isn't one person managing blood sugar, one person managing renal comorbidity, one managing cardiovascular comorbidity. We've seen that all of these intersect at the center of optimal management, and I think the implementation of best therapies across this spectrum are critical, and I think we're failing a bit, quite honestly, as a clinical community. Guidelines have been amazingly fast to change, which I'm impressed with, and the data is robust. So I think our biggest challenge is how do we break down the silos of thinking more about cardio and renal protection rather than just who owns which part of this, and that's something that we all have to work on together.
Excellent. Thank you. Susan, what are your thoughts? I mean, what are your thoughts on how we work together from a healthcare provider community, but how do we also engage our patients and address their needs?
Yeah, it's always a challenge for me because oftentimes mental health services, especially with patients with diabetes, are delivered outside of the medical system. I do think that this integration what Dr. Cooper just said is so important to help us work together as a team. And when we're talking to people, I really appreciated what Donna said earlier about talking to patients about what these numbers mean and why these medications may be labeled one thing, but they're for another purpose, for blood pressure medication. Sometimes when I'm seeing people that are referred to me for medication taking challenges, that people often don't even know why they're taking them. And you just presented some beautiful data about good news. And we often don't talk to people about what the benefits are for what we're recommending, and we're just talking about what happens if they don't. So if you don't do this, you're going to have kidney problems, or you may end up on dialysis. But without talking to people why they should bother, they don't really know that their efforts can have a positive impact. And so I echo that we really need to be working better as collaboratively so that we aren't in our silos and we do are better cross-trained so that we can treat the whole person. And I think our outcomes would really improve if we did.
I agree. And, I know from my perspective, I always try to get patients to understand, here's why we're treating you, what we're trying to accomplish, not just today, but longer term, and then what to expect. And so I think when you hit it really on the head, that if we need to make sure the patients understand the expectations so that they're actually much more adherent to our recommendations. Donna, what are your thoughts about this? What's your view? And also, when would you refer a patient?
Okay. It's a perfect opportunity for diabetes care and education specialists to play a very vital role here in helping us to look at not only diabetes management, but we've always looked as diabetes educators at their blood pressure, their cholesterol, things like that, but we didn't always pay as much attention to chronic kidney disease. And as we're broadening our reach in becoming a diabetes care and education specialist, I think it's important, and I think it's much needed that we also include chronic kidney disease in our thoughts and in our practice. And so I'm so glad that that we're expanding our reach, and I think it's important to start thinking about some of these things. We're a good place. Our group is a good place to bridge some of the gaps in, or some of the pieces. We can put it all together. When I refer patients to nephrology, when a patient's estimated GFR, when they get to stage 3, it's when they start to have a lot of symptoms and they start to have manifestations in some of the other areas such as anemia, bone disease, things like that. So especially if you have somebody that's at CKD stage 3, I think is a good time to refer a patient to get them in with nephrology so that some of the other complications of kidney disease can be addressed. But certainly very early on, if you have someone with rapidly declining renal function or with significant proteinuria that you can't account for, the cause. So those are the type patients that I refer to nephrology. And Dr. Cooper, if he's still here, may have some additional thoughts about that.
Thank you. Just a quickie comment. SGLT2s are, in the United States anyway, are not indicated in type 1. It's because there's slightly increased risk of